Welcome back to the channel. Today we are tackling a critical topic in transfusion medicine, that is TRALI versus TACO. What is the difference and why does it matter? Let's break down it today. Before going into the topic, let's see the classification of the adverse transfusion reaction. So the adverse transfusion reaction is basically classified as hemolytic transfusion reaction, non-hemolytic transfusion reaction, and transfusion transmitted infection. In hemolytic transfusion reaction, there is a two type of reaction, that is acute and delay. So if any reaction which is coming in less than 24 hours is termed as the acute reaction, whereas any reaction after 24 hours is said as the delayed reaction. In non-hemolytic transfusion reaction, these can be further classified as the FNHDR allergic reaction, PTP, TAGVHD, TRALI, and TACO. Transfusion transmitted infection, they are further classified into one category, that is transfusion related sepsis, or we can also say that it's a septic transfusion reaction. So in this video we will be focusing on the TRALI and the TACO. So TACO and TRALI, they are the serious ATRs in the blood transfusion department. So TACO is the most common respiratory adverse event which is associated with the transfusion, and it is the leading cause of the transfusion related mortality according to the both UK short and the US FDA. The main changes included increasing the onset time, that is from 6 hours to the 12 hours, a broadening of supportive cardiovascular sign, and a formal inclusion of biomarkers. So according to the two definition, one was given in the 2004 and the another was given in 2019. So according to this definition, that is uh, given by CCCR, that is Canadian Consensus Conference. So they said that the TRALI is divided into early, that is acute lung injury, which is said to be when there is acute onset of it, hypoxemia, which is said like when the partial pressure of oxygen is less than or equal to 300 mmHg, or SpO2 is less than 90% on room air, or any other clinical evidence of hypoxemia. There presence of bilateral infiltrates on chest x-ray, and there is no evidence of LAH, that is the pre-existing circulatory overload, or there shouldn't be any pre-existing acute lung injury before transfusion, and it should occur during or within 6 hours of transfusion, and there is no temporal relationship to the alternative risk factor for the early. Then it is called as TRALI according to the 2000 CCC definition. But according to the revised definition, they have classified TRALI into TRALI type 1 and TRALI type 2. So the type 1 includes the patient who have no risk factor for the ARDS and meets the following criteria, like the ARDS is very acute onset, hypoxemia is there, SpO2 less than 90% on room air, partial pressure of oxygen less than equal to 300 mmHg, and there is a clear evidence of bilateral pulmonary edema on imaging, and no evidence of LAH, and if at all, if LAH is present, it is not judged not to be the main contributor to the hypoxemia, and it should occur during or within the 6 hours of transfusion. And similarly, there is no temporal relationship to the alternative risk factor for the ARDS. So in possible early, there is acute lung injury, no pre-existing early before transfusion, and it should occur during or within the 6 hours of transfusion. There is a clear temporal relationship to an alternative risk factor for early, whereas there is a no temporal relationship seen in the TRALI according to the 2004 CCC definition. In TRALI type 2, the patient who have the risk factor for ARDS or who have existing mild ARDS but whose respiratory status deteriorates and is judged to be due to the transfusion of the blood or other products. So the findings which we described in the TRALI type 1A and B section, those all the findings are included in this also. So the difference in TRALI 1, there the patient doesn't have any risk factor for the ARDS, whereas in TRALI type 2, the patient is having the risk factor for the ARDS. And here in the TRALI type 2, there is a stable respiratory status in the 12 hour before transfusion. Now, what are the risk factors for the acute lung injury? So there are direct and indirect risk factors. So the direct includes pneumonia, aspiration, toxic inhalation, lung contusion, near drowning, and the indirect includes severe sepsis, multiple trauma, acute pancreatitis. So according to the definition 2004, they have also said that because of the burn injury, shock, drug overdose, cardiopulmonary bypass, this all can become a risk factor for the early. Now, according to the ARDS risk factors, they are again classified as the direct and indirect. So the direct includes pneumonia, aspiration of the gastric content, inhalation injury, pulmonary contusion, pulmonary vasculitis, and indirect include non-pulmonary sepsis, major trauma, pancreatitis. And according to the revised 2019 classification, severe burn, non-cardiogenic shock, and drug overdose can also be the risk factor for the TRALI type 1 and type 2. TRALI incident is ascertained because of its under-recognition and under-report. The reported mortality ranges between 5% and 24% respectively. According to the 2004 definition, they have defined TRALI as the acute onset hypoxemia and the pulmonary edema occurring within 6 hours of transfusion in patient without the evidence of the left atrial hypertension and no pre-existing or alternative risk factor for the acute lung injury. So the patient with an alternative early risk factor they have classified into a possible TRALI. And according to this 2019, which is a revised definition, it improved the understanding of TRALI and it aligned with the change in the terminology from the early to the acute respiratory distress syndrome. So this new definition gave a new nomenclature, that is TRALI type 1 and TRALI type 2, to replace the TRALI and the possible TRALI respectively. So the patient with the pre-existing ARDS but the stable respiratory status in the 12 hours prior to the transfusion can be diagnosed as a TRALI type 2, whereas they would have been excluded as having a possible TRALI. If we see, there is a acute lung injury after the blood transfusion in TRALI, and for the diagnosis, these 5 points are important. Like there should be acute onset, that is within 6 hours, that we have discussed in the definition as well. Hypoxemia should be there, and the chest X-ray shows the bilateral pulmonary infiltrates and no evidence of LAH, and there should be no ALI. So alternative risk factor for the TRALI include, but not all limited to, the aspiration, pneumonia, sepsis, multiple fracture, pancreatitis, shock, and cardiopulmonary bypass. If criteria 1 to 5 are met, but there are temporal association with the early risk factor, then these can be categorized as the possible TRALI. Now, pathophysiology of TRALI. So basically, the pathophysiology of the TRALI is occur because of the three mechanisms. Number first is the antibody hypothesis. This occur because of the presence of HLA, and HLA, as you know, that can be class 1 or class 2. Both are involved in this hypothesis. Second mechanism is the biologic response modifier. These are not because of the antibody mediated. And the last mechanism is a two hit theory. So there are two events and one is the opportunistic event. So first, antibody mediated lung injury, which involves your HLA, that is type 1 and type 2. So it occurred in 70% of the TRALI cases, and 85 to 90% is the component based, and the 5 to 10% is recipient based. So HLA and HNA antibody formed during the transplantation, transfusion, or pregnancy, and these antibody they target the WBC, and which lead to pulmonary microvascular infiltration and the damage. See in this diagrammatic view. So if we transfuse a blood component, so the blood component contains the antibody which interact with the cognate antigen which is present on the polymorphonuclear neutrophils. Then these antibody interact with this antigen on the recipient PMN. These will lead to the aggregation in the pulmonary microvasculature, and it will lead to the activation of the nuclear cells. Then after the activation of the PMN, they will produce or release the reactive oxygen species and enzymes, which in the absence of the microbial target instead cause the damage of the pulmonary endothelium. So once the endothelium get damaged, this will allow the leakage of the fluid in the pulmonary space, and which lead to the clinical symptom of the respiratory distress in the TRALI. So this is our first mechanism how the antibodies, with that is the human leukocytes, antigen and antibodies, they are reacting and causing the damage in the pulmonary endothelium, which leads to the respiratory distress symptoms. Second mechanism is the biological response modifiers. These are not because of any type of antibody. This occur because of the accumulation of neutrophils in a long stored blood. So these are independent of antibody, and there is a lower morbidity and mortality risk. So now the third is the two hit story. So the first hit is the patient factor, which can be anything like sepsis, hematological malignancy, patient underwent heart surgery, patient is on mechanical ventilation, or age of the patient is in shock. So this all factor will become the first hit. The patient is already in the immune compromised type of a situation. Now the second hit is the transfusion factor, whether we are transfusing the RBC, FFP, platelet. So these contains the antibodies, HLA antibodies, HNA antibodies, some bioactive lipids, or because of the age erythrocytes, which will become the second hit. So let's see in detail. The first hit is the neutrophil sequestration and the priming. What has happened? The patient factor, that is the sepsis, shock, or some kind of a surgery. So this will lead to the endothelial injury, which will cause the upregulation of the adhesion molecules, and the neutrophils sequestered and priming occur, that is the cytokine release. Then the second hit, now we are giving the blood products. So the blood products will activate the neutrophils, and this will cause the release of cytokine and reactive oxygen species, so which will cause the damage to the pulmonary capillaries. Once the pulmonary capillary endothelium got damaged, it will lead to the pulmonary edema. Now, the TACO definition. According to the 2011 ISBT or IHN definition, the TACO is characterized by any four of the following. Either there be acute respiratory distress, tachycardia, increased blood pressure, acute or worsening pulmonary edema on frontal chest radiograph, evidence of positive fluid balance occurring within 6 hours of completion of the transfusion, or there is elevated BNP in supportive of TACO. According to the 2018 ISBT IHN ABV definition, the patient classified with TACO should have acute or worsening respiratory compromise or evidence of the pulmonary edema during or up to 12 hours of the transfusion, presence of at least three or more criteria, which are like acute or worsening of respiratory compromise, evidence of acute or worsening pulmonary edema based on the clinical physical examination or the radiologic examination, and there should be other in non-invasive assessment of the cardiac function. And the third one is there should be evidence of cardiovascular system changes which cannot be explained by the patient underlying medical condition, which can be tachycardia, hypertension, widening pulse pressure, jugular venous distension, enlarged cardiac cell house, or peripheral edema. There should be the evidence of fluid overload during any kind of like situation, there should be a like positive fluid balance, response to the diuretic therapy. So patient is responding to the diuretic therapy, or there is a change in the patient weight in the peri-transfusion period, and supportive result of relevant biomarkers. So we will be checking the BNP or anti-pro-BNP above the age group specific reference range or greater than 1.5 times the pre-transfusion value. Then you can say that it can be a taco. So as we discussed in the definition, TACO occur when there is a pulmonary edema which developed due to the volume excess or circulatory overload. What can be the risk factor? It is extremely age related, or some diseases like cardiac, renal, pulmonary, hematological or oncology diseases, hypoalbuminemia, rapid blood product administration, and for the diagnosis there should be more than three criteria which is involved within 12 hours of the cessation of the transfusion. It can be acute respiratory distress, elevate PNP, elevate CVP, evidence of left heart failure, evidence of fluid balance, and in the chest x-ray it will be showing the pulmonary edema. So now see the difference between TACO and TRALI. In TACO, the etiology is too rapid or excessive blood transfusion or both, whereas in TRALI it occurs when there is a passive infusion donor HLA or leukocyte antibody through plasma containing components and the recipient antibody to the donor, which lead to the microvascular injury in the lungs. Now how the TACO patient represent itself? There should be dyspnea, cough, rales, increased systolic blood pressure, headache and cardiac arrhythmias can be present, whereas in TRALI there is fever, dyspnea, hypoxemia, hypertension and pulmonary edema. For evaluation, if we see the chest x-ray, there will be bilateral infiltrates in TACO, and you can also go for the BNP and pro-BNP. If it's more than 1.5 above than the pre-transfusion value, then you can also say it's a TACO. And whereas for the TRALI there is pulmonary edema, and we have to also rule out the hemolytic transfusion reaction. And for the treatment, if you give the diuretics to the TACO patient, the patient will improve, and we have to stop the transfusion, make the patient upright, give him or her the oxygen therapy. For the TRALI patient, you have to give the respiratory support to the patient, and prevention is better. So for the prevention is leukocyte reduced blood component should be given to this patient, and not to use the donors previously implicated in a case of TRALI, usually a female with a history of pregnancy or transfusion. So if you like the video, kindly share, like and comment, and tell me in the comments like further on which topic you want the video. Thank you.